On behalf of the National League of Cities, I welcome you to this important dialogue on city and health system partnerships. I am Sue Polis, the Director of Health and Wellness with the Institute for Youth Education and Families at the National League of Cities. It's an honor to talk with you in these most challenging times about the need, value, and urgency for stronger collaboration to improve community health and well-being. So why are we talking about partnerships between cities and health systems right now? Perhaps at no other time in our country's history has collaboration been more critical. In the wake of COVID-19 and racism pandemic, NLC is launching a new effort focused on forging robust city health system partnerships to improve health outcomes and advance equity for the most vulnerable, a complex challenge that calls for transformative and collaborative efforts. As we recently announced the formation of a new learning community for up to 12 cities to join, this effort aims to offer expert coaching, in-depth assistance, tools, and resources to support greater alignment around pressing community needs. To lay the groundwork for this opportunity, it seemed essential to hear from stakeholders with lived experience who can share their insights to help cities consider participating in this opportunity. I am truly humbled and delighted to moderate a conversation between former Kansas City Mayor Sly James and Kevin Barnett, who is with the Public Health Institute and Executive Director of the Center to Advance Community Health and Equity. Mayor James served as Kansas City, Missouri's mayor from 2011 up until last year. And during his tenure, his city won the coveted Robert Wood Johnson Foundation Culture of Health Prize. The prize was awarded recognizing the commitment, work, and efforts in Kansas City to improve health for a focus on root causes of disparities, including the gaps we see in life expectancy, often concentrated in zip codes. When we think about health, we tend to think about visits with health providers, physicians, and nurses, and other healthcare professionals, and/or our behaviors. But as Mayor James has demonstrated through his leadership, city leaders have as much or more of a role in community health improvement than one might initially expect. Through addressing the social, economic, and environmental factors that determine how well we live and how long we live, including housing, air and water quality, education, employment, community safety, among other factors, local leaders have many levers to improve community health. But we know no one person or entity can solve these problems alone. Also joining Mayor James for this discussion is Kevin Barnett. Kevin is a national leader on efforts directed at improving health system engagement to advance well-being. Kevin not only serves on health system boards and works in many communities to help strengthen partnerships, he will be working with NLC to lead this new community of practice by sharing his expert insights through his ability to guide and coach city leaders and health system stakeholders to partner together to work to address the most pressing unmet community needs. NLC is grateful for the support of the Robert Wood Johnson Foundation for this timely opportunity. Given the great uncertainty across our country, there is perhaps no better time to work together to address the most urgent needs in communities, to forge new paths forward together, and ultimately improve health. And with that, I'd like to begin with a question for both Mayor James and for Kevin. Let me ask you, what can hospitals do for the good of communities, and why should they?
I would start by saying that we are at an inflection point in the healthcare arena where gradually but surely hospitals are assuming increasing financial risk for keeping people healthy and out of acute care settings. In that context, and particularly in the urban environment where we have such high concentrations of poverty and socioeconomic challenges and related issues, that they have an important role to play. They are among the larger employers in our communities and have a clear set of contributions that they can make, given the fact that they have set of patient populations that they work with and the opportunities to look at ways in which to more proactively and cost effectively manage their conditions. Our come to grips in the healthcare arena some years ago was that the fee-for-service system of financing is unsustainable. The continued upward cycling of healthcare costs are moving beyond even middle class communities in our country. And it behooves us as a nation that has not invested in prevention to begin to turn that ship around. And hospitals have a key role to play in that process.
You're going to hear from me a lot about the concept of preventing as opposed to repairing. Our entire society seems to want to let things break down before we address it. When if we simply do the preventative measures up front, it won't break down, or it won't break down as badly, or won't break down as often. That's true regarding healthcare as well. When we have hospitals that devote a huge amount of their time and resources to caring for people with diabetes, heart disease, things of that nature, environmental issues, it would make more sense to spend a fraction of that money that they spend to take care of them to try to prevent it than it does to just simply wait until they have it and then try and fix it. Diabetes in the African American community is a prime example. Much more expensive to treat diabetes than it is to engage in a deep instructional approach to preventing it or providing the things necessary to prevent it. And that's kind of where cities can come in and help, is by eliminating food deserts and things of that nature, so that people have the types and the quality of food that they need and don't rely on things that are unhealthy for them.
Thank you, Mayor James. I'm going to ask Kevin to just talk to us a little about some of the historical and evolving roles of hospitals in cities, and why should we care about it now, Kevin?
Of course, our hospitals started in our cities well over a century ago, and in the early days served a role, and for all intents and purposes, in warehousing people with infectious disease, lower income populations. The more affluent could have doctors come to their houses. And these hospitals played an important role. In fact, there was a time when our public health officers were based in these hospitals in cities, because it was the place to begin to understand and address the epidemics that emerged of infectious diseases from time to time. As we moved forward with technology, as hospitals became increasingly places for treatment, for surgery, for procedures for populations, it became more attractive. It became a greater significant source of revenue for these organizations. Many of our early hospitals were public, but over time, it became clear that there may be a more cost-effective alternative to public hospitals, and the emergence of nonprofit hospitals was an alternative to direct financing in the public arena. In the 70s, cities began to question whether or not nonprofit hospitals were effectively fulfilling their obligations during a time where we saw what is often referred to as white flight, moving of middle-class white populations into the suburbs, and leaving behind increasing neighborhoods of low-income populations, often predominantly communities of color. And appropriately, cities began to ask the hospitals, why should we defer millions of dollars of tax revenue, property tax revenue, when you are jumping over these populations and serving the more affluent Caucasian populations in the suburbs? Unfortunately, while we are seeing some trends in a positive direction, the vast majority of what nonprofit hospitals contribute in the form of what we call community benefit is still the treatment of what are to a significant degree, if not the majority, of preventable conditions in emergency rooms and inpatient settings. So as Mayor James noted, particularly our epidemic of diabetes is one of the most significant challenges that we face. To the degree that some have documented this, Kaiser Permanente among them is one of our few vertically integrated systems that operates under a full risk capitated environment. They've documented billions of dollars of loss in a system that does an excellent job of care coordination. Their observation appropriately is you simply can't care coordinate your way out of a major chronic disease like diabetes. You have to prevent it from occurring in the first place. And we simply can't do that in neighborhoods where people have no access to affordable, healthy foods. And they live in housing with cockroaches and dust mites and 30-year-old carpets and mold and the kinds of factors that contribute to other chronic diseases like asthma. In essence, it's staring us in the face that we have to be more proactive about addressing this, and our hospitals have to be a part of that solution.
Thanks, Kevin. And as you talk about sharing the burden in communities, could you help us think about the range of alliances from your perspective that are possible as hospitals think about becoming more intricately and integrally engaged with local political leaders?
Well, first of all, I think that a lot of the problems that we've been discussing are directly related to the issue of poverty in this country. Poverty in this country is not going to be resolved, solved, or reduced by hospitals. It has to be something where the root causes of poverty are examined and worked on. And that requires long-term thinking, long-term political thinking, long-term policy execution. All these things are doable, but it requires a shift in thinking that we frankly have not seen on a broad enough scale, but it also requires a coordinated systemic thinking plan that is going to be implemented over time. And in the political systems that we have now, where you are term limited every 4 years or 8 years, once a new political regime comes in, focus often shifts and you're off doing something else. So something that takes 20 years to really do and do well only gets a third or half of the amount of time that it needs, and then it kind of filters off. So a lot of things have to be changed, but the main thing is there has to be a commitment to a different way of thinking.
Mary James, you just said that so well. You know, part of this initiative that we're helping to support cities and these health system stakeholders are part of our Cities of Opportunity initiative with the Robert Wood Johnson Foundation, aimed exactly at what you're talking about, these long-term plans that need to be seeded, need to be developed over time. And we know you pointed to this in your comments around the fiscal challenges. So, Kevin, I want to ask you, prior to COVID-19 and what we're living through at this time, there are a lot of trends happening within healthcare financing and incentives and certainly challenges. Could you talk to us a little bit about some of these trends and their implications and how we can start thinking about innovations in financing to help drive and support this work?
Sure. If I could, just quickly though, I'd like to put a point on a really an essential issue that Mayor James raised, which is, in fact, one of the core messages of our center, which is shared ownership for health. I've spent much of the last decade and a half engaging board members of hospitals and health systems around the country. And I have seen this pattern as I engage them and provide a picture of really what we're confronted and how it directly relates to our expenditures in the healthcare arena. And the most frequent reaction after, oh my God, I can't believe how complex these problems are, is are we supposed to solve these problems? And we have to help them grapple with where the hospitals fit into the picture and how the other stakeholders come to solve these problems together. It's clearly not just on the shoulders of the hospitals. There are many of these issues that their most significant role is simply using their voice because they are respected, because our medical professionals are respected. They owe it to themselves, to their organizations in their communities to speak about these issues. Now, as it relates to healthcare financing, we are moving increasingly in the direction of what we call value-based care or value-based reimbursement, where in essence, the end state of this is payment, a per member per month payment that that is received, and hospitals and health systems and payers will have to come together to look at ways in which they share risk from these payments to increasingly emphasize how to keep people out of our acute care facilities. Interesting thing about COVID is obviously the front end in our confronting this pandemic has been, oh my gosh, we need every ICU bed that we have, and we need more. For many of our cities, we looked around just a year ago and said, we are way overbedded. We have too many beds for the emphasis that we should have on prevention. So we've got this time where we welcome and appreciate the high level medical expertise of our health professionals, but we can't lose sight of the fact that our larger movement here is how to prevent these conditions from creating the kind of havoc that they do.
Thank you, Kevin. And Mayor James, you build on this theme Kevin just mentioned about the connections across education, early childhood, and so forth. You know, from your perspective, are we asking the right things of different parts of city government, public health, all these different levers within city government? What can we do better?
Well, I think sometimes people overestimate the reach of city government. City government has so many responsibilities and so little money to cover all the responsibilities, and such a diverse clientele that it's very difficult sometimes to marshal the resources necessary to attack a specific issue, which is exactly why there has to be public-private partnerships. City government is responsible for everything from sweeping the streets to providing for healthcare, to providing for police protection, to responding to pandemics, et cetera, et cetera. It is a heavy burden to put. It requires a level of expertise across many different departments that some cities simply cannot muster. Here's another thing that I want to piggyback on what Kevin was talking about at the beginning of what he started saying in the last segment. If these types of things are going to actually succeed in the long run, two basic things need to happen. A lot of times foundations are involved in these processes. Foundations need to be asking, how are we going to ensure that whatever program that we start with you are going to be sustained beyond the next administration and the next administration? Will this city pass an ordinance, hopefully, or a resolution minimally to ensure that it survives beyond the next administration, or at least there's some public intent and statement to do so? Secondly, you have to get things out of City Hall into the private sector to be housed and owned to ensure that long level of continuity. Because City Hall changes too frequently. Don't forget, as much as we try to avoid politics on the local level where it's nonpartisan, politics enters into it, and that's simply politics in the form of how do we respond to today's constituent demands. And sometimes those constituent demands change.
So important to really draw that contrast of what's required over the long term. Mayor James, thank you for raising that. And Kevin, I just want to give you a chance to reflect on Mayor James's comment. I know you share that perspective. How do we help catalyze these longer term investments that really are needed to change the trajectory of community health improvement, particularly for our most vulnerable?
Yeah, I guess I would start by noting that as I've engaged the senior leaders of hospitals and health systems in particular around this issue of civic engagement, of course, our hospitals have participated in the political arena for many years, but most of that participation and advocacy has focused on increasing reimbursements. Most of that is focused on maximizing their revenue. They have not historically than compelled in any fundamental way to look outside of their doors and look at and address these issues, with the exception of really important but mostly small-scale efforts that people leading their community benefit departments have undertaken. So now, coming to grips with the structural inequities, the structural racism in our society, and the way it manifests itself, and the way it contributes to multi-generational poverty and suffering, and a range of social challenges, is the question: what can we do? There are ways in which we can allocate resources. There are an increasing number of hospitals and health systems that are allocating a small portion of their investment portfolio specifically to look at ways in which to stimulate, accelerate, and scale investments in things such as affordable housing and healthy food financing, small business development, and the like. And also are, as the common term emerging, are serving as anchor institutions, and that is thinking comprehensively about what are the ways as large employers and organizations we can contribute to good.
Thank you, Kevin. So helpful. And I think, just reflecting on your comments, I'd ask Mayor James, as you think about this conversation about, your experience, what advice would you have when you talk so profoundly about philanthropy and taking a longer view, private-public partnerships, but what's a good first step, or what advice would you, from a practical standpoint, what advice would you have for cities who are thinking about embarking on this work to strengthen these partnerships with their health systems?
First of all, I think that you need to become systems thinkers, okay? You need to understand the connectivity of things and how things done now affect something tomorrow. Secondly, I think you need to become ultra sophisticated with the use of data and facts to make decisions as opposed to politics and supposition. In order to become facts and data based, you have to actually do things like we did in Kansas City, which is to have a citizen satisfaction survey that we aggregate over periods of time, along with 311 data, along with data from every other source and anecdotes, etc., and look at it. And then, instead of working through individual departments, bring the necessary people from divergent departments together in order to address the problem, as opposed to addressing the department. Shift from a siloed departmental approach to running cities to a problem-solving approach, which requires different people from different departments to collaborate and work together, because each of them play a role.
My goodness, great advice. And I'm going to wrap us up here with our last formal question. But before I do that, Kevin, anything that you'd want to hearken from Mayor James's point about the connectivity and the need to work across?
Well, I think he articulated it so well, and it is something that it does require systems thinking. It does require us to step outside of our particular areas of expertise and explore, how do we do this work together? How do we get beyond the politicization of so much of what we grapple with, and see ways in which we can solve problems together? I don't think there's much more to say than that.
No, thank you so much. And so I'm going to wrap up with our final question. And I want to reflect on what you've already both pointed to, our structural racism issues in this country amidst this pandemic that's been brought upon our country. What can we do to build a more promising and equitable future? What is the moment calling for?
The whole idea of racism, systemic or otherwise, is a broad concept understood in 50,000 different ways by 60,000 different people. There has to be a developed commonality of language, which requires education. Don't forget, not everybody is starting from the same place. Some people actually think that African Americans came over here on vacation and decided to stay. It was such a lovely place. Okay, that kind of stuff and they don't understand why there's rioting. They think that the phenomenon of black men being killed by police is a new phenomenon, when the only thing new about it is the fact that phones have cameras now. Same thing's been happening for decades, happened when I grew up, etc. There has to be education. Not going to solve any of this until people have a greater understanding of what the reality of this country has actually been. The promise of the country has been often talked about. We all believe in that. We all love the country. But the reality, the history of this country as it reflects on African Americans, on Native Americans, on immigrants, is not told in complete fashion. If you're going to change racism, then you have to change the understanding of what racism is and how it came to be about. You can't dismantle a car unless you know how it was put together. And and a lot of people simply have no idea of how racism was put together in this country, and therefore no idea of how to dismantle it. It starts first with individual commitment to educate yourself about what the situation is and how it came to be.
And Kevin, I'd like to ask you to reflect and add on that.
Sure. Well, I would say that just as we are a nation of hyper-individualistic culture, where we have lived the delusion that all one needs to do as an individual is to work hard and pull yourself up by your bootstraps and you will succeed. And we are also an ahistorical nation as well. But we are taught in the K through 12 arena is largely highlights of positive history with an occasional sad story here and there. But by no means do we help our people understand at a very early stage just how brutal we have been to various populations throughout our history. It doesn't mean that those of us that were just born a few decades ago need to feel guilty about that. And I think that is part of what gets in the way of understanding and moving forward, is that the typical reaction of a Caucasian is, well, I didn't do that. I'm not a racist. That's not where I'm coming from. And instead, we have to open our minds and our hearts to understand just how much damage was inflicted upon our brothers and sisters from all backgrounds in our history.
And you said it, what we need to do together. It starts with each of us individually, as Mayor Jane said, pushing ourselves, pushing our colleagues, I think, to have these honest conversations and really working to guide a different value set over time for how America is going to come to this more transformative moment that's so needed.
In having those conversations, it is critically important that you start off by having an understanding of what the terms actually mean. There has to be a common understanding, because if you walk into a room with 50 people and say the word racism, there will be 48 different understandings of what that means. And by having that understanding, you avoid exactly what Kevin was so rightfully saying about feeling guilty. This isn't about guilt. This isn't about trying to make folks feel uncomfortable. If they have an understanding of what systemic racism really means, they will understand that they are also victims of systemic racism in a different way. And that takes a lot of the guilt and pushback and defensiveness out of it. And then you can have a conversation about what to do about it. But you have to get past that sticky, uncomfortable part first. And definition are the way to get there, at least get started.
Amen.
So profoundly well said and important. And I can't thank you both enough for this amazingly thoughtful conversation. Excited, even though we're in such difficult circumstances, to know that there's paths forward and things that we can do proactively in partnership and alignment to drive systems change forward. And so I just want to say, on behalf again of the National League of Cities and the generous support of the Robert Wood Johnson Foundation. We're so delighted to talk with you both today as part of the Cities of Opportunity Initiative, and to get our work to roll up our sleeves and work to help to drive these transformative partnerships. And briefly, I want to thank Laura McDaniel, health manager, who champions and supports all of this work and guides this work. I know folks will be reaching out with a lot of questions, Laura, with your leadership of this effort, and so grateful for all your efforts to put this together.